I'll be talking today on anticipated difficult airway management. How do I address this? After Nagaraj's talk, it will be very much easy for me to go ahead with those things. I've been searching for the literature and all. I've seen something like this. Anticipated difficult airway is that you know the problem is already settled. And the unanticipated difficult airway is you don't know when it comes to you. But the final outcome will be the same, delicious. The meat or masala or algorithms, everything sets into a same and collide at one stage and go ahead with the final outcomes. Many algorithms came in. This was the latest one from NEGM, May 2021 almost. And almost you see all the algorithms almost they say the same thing. If it is unanticipated or anticipated, you need to plan things, you need to deliver goods, you need to have an algorithm, whoever you may be, you need to be sticking to the algorithm and go ahead. So at one stage, this anticipated difficult airway also merges with the same algorithm and goes ahead when the situation of cannot intubate, cannot ventilate, or cannot intubate, can ventilate situation comes in. Intubation for a anesthetist or a critical care physician or emergency physician is a common scenario actually, as is cricket for our Indian team, but we know what happened. First attempt is the best attempt. Okay, you miss it. Second attempt at least. If you miss that, then you are in problem. I'm not criticizing anybody, but this is the, literature given by the NPA4, as sir was also mentioning. Human factors have a great role to play when you are dealing with difficult airways. 40% of human factors contribute to the adverse effects as per the NPA4 this thing. And the best anesthetic teams supported by best guidelines will still struggle to perform optimally if the system is having some operative flaws or something. And they saw many angles out of it, like poor communication, poor training and teamwork, deficiencies in equipment, and loss of situational awareness by the team, and subsequent poor decision making will create more problems. I'll try to focus on different domains, as sir has already gone through many the algorithmic part of it and all. I'll have my own way of dealing this. So we'll be first discussing problem incidents, planning and preparation. How do you do that? How to communicate in a team whenever you are in such a stressful condition of managing a difficult airway. How to optimize things whenever you are in trouble. Managing anticipated difficult airway which are very high risk. I'll be showing you how we go ahead. How to troubleshoot whenever you have problems with FOB and Videolaryngoscope, and how to deal with cannot intubate, can ventilate, and cannot intubate, cannot ventilate scenarios, and a small focus on role of point of care ultrasound on dealing difficult airways, because I am dealing with anticipated, so we need to be ready with every armamentarium in us, and the last would be the take-home message. So you have been listening since yesterday, I think, the problem, what is the incidence, how frequent it is, but though it's not so frequent, but anybody can land up in a difficult airway at any time, whether it is anticipated or unanticipated. So the incidence would be 5 to 8% as per the global scenario, and when you look into All India Difficult Airway Association paper, it's almost 8 to 13% in our Indian ICUs and emergency departments. How do I plan things and prepare for this anticipated difficult airway? So whenever you go on rounds in the ICU, or whenever you are planning a case in operating room, you need to anticipate difficulties for every intubation. plan for managing the difficult airway. You need to sketch out the plan how to go ahead with such patients. And all the team members should be clear about the plan. Somebody is thinking of some other plan, somebody is thinking of some other plan. No, it's not like that. So everybody should have a clean sketch out plan for everybody. And a good communication in terms of a team always fetches you good results. So how do I prepare? When I'm dealing with an anticipated difficult airway, I'll try to keep a difficult airway cart ready with me, which has 4 drawers. The first drawer, I'll try to keep the laryngoscopic equipment. The mandatory would be 2 laryngoscopes, 2 well-working laryngoscopes, a face mask, ET tubes of different sizes, Meigels forceps, tillet, and a bougie. And optional would be a videolaryngoscope. And the second drawer, a mask ventilation and alternatives. The mandatory would be oropharyngeal airway, nasopharyngeal airway, and optional would be high flow nasal cannulas, McCoy blades, and fiber optic bronchoscopies. In the third drawer, rescue ventilation and tube exchangers. My supraglottic airway devices will be there, an ambu bag, and airway exchange catheters, and an NG tube. The fourth drawer will be having emergency equipments, cricothyroidotomy kits, or devices. I mean, you don't have to have a kit all the time. You can make it by needle, guide wire, and all these things, a scalpel, and a 6 mm ET tube. So you need to have this cart ready in your ICU or OR so that you can push in whenever you have a difficult airway. Communication again plays a major role whenever you are saying that human factors are contributing for 40% of adverse effects and all. So you need to cut down that 40%. So many a times you see either your colleague, your subordinate, or your just senior or just junior will be intubating, and you know that he is going wrong, but still you doesn't stop him or resist him just because you think that he may feel bad or something kind of. But there's always a point there, because at the end you shouldn't fail multiple times and land up in difficult scenarios. So always try to communicate in a model, kind of like there's a PACE model which have been explained, like you probe, you alert, you challenge, and then you raise the emergency. How do I do this? Probe. So when you see somebody ventilating, okay, one of my colleagues is ventilating, and I see, if I am not able to see the chest raise, I gently say him, is the chest raising? I'll just ask him a question. I'll just try to probe into it. Okay. So if he is not responded, he has not, corrected his way of ventilation and all these things, then I'll alert him. I'll increase my voice. I'll be more louder. I'll call him by his name and say, I cannot see any chest raise when you are ventilating and all. Even then, if he is not changing his maneuver and all, then I'll challenge him. I'll call him by name. I'll say that the chest is not rising, the patient is desaturating, can I take over? Okay, you don't have to be harsh enough, okay, you can be gentle enough, talk to him properly, and call for help always. And if still he is not changing, then you call by name, you say chest is not rising, the patient is desaturating, is blowing off, I'm going to call for help and I'll take over, okay. So you don't have to be panicked in a team. If you are a team leader, or you are intubating, or you are giving the guidance for intubation and all, if you get panicked, the whole team will get panicked. So you need to be strong enough. Okay, how do I optimize? I'll try to focus on practical issues, what usually we see whenever we are intubating a patient in a OR or a ICU. Many a times we forget removing the rails of the bed, we don't know where the patient is, how far he is from us, what is the height of the patient from us. So you need to optimize all these things to get a better airway. So always focus on the success in the first attempt. Okay, so that is the best attempt for you. So when I deal with obese patients in an operating room I always have a luxury of operating beds where you can just break them at the head level and give a head up, ramped up position like this. And if you doesn't have so in ICUs, at least you can put some linen, rolled linen in at the back and at the neck and get a ramped up position. The main aim is to get this external aortic canal or tragus to the chest height. Okay, so that always improves the visualization in obese patients. Traditionally, we are taught CE position of holding the mask, but many a times inexperienced people or inexperienced staff may be holding a mask, something kind of like this. When you hold something kind of like this, you will be pushing the soft tissue into it and making your ventilation difficult on your own. So you can modify yourself to hold it in a VE position at least, so that you can get a jaw thrust, you can open the airway, you can ventilate the patient well. Okay, so you are finding difficulty with CE position, switch over to VE position and ventilate. Okay, now we will discuss how to go ahead with the anticipated difficult airway. Whenever you see an anticipated difficult airway, if you think it's an high risk, always try to keep your patient awake and go with an awake intubation and all. If you try to intubate a patient and all and you fail intubating, then you go ahead with, as sir was mentioning about the algorithm and all, the next would be your supraglottic airway devices. Then if you are not able to do so, then your front of neck access comes into play. Traditionally, whenever we were trying to do awake intubations and all, prior we used to do blind nasal awake intubations and retrograde intubations. But after the commencement of fiber optic bronchoscopes and videolaryngoscopes, the trend has changed. We stopped doing blind procedures in operating rooms or ICUs. So we try to use fiber optic bronchoscopes and videolaryngoscopes. Whenever I am anticipating a difficult airway, I'll try to keep them ready. We have an Ambuscope with us, which we always keep it ready to go ahead with difficult airways. We usually get such kind of patients where you have some rhinophyma where you can't ventilate your patient well, or TMJ ankylosis or upper lip tumors, or this was a recent case what we had, a tongue tumor or a tongue flap over the palate and all. So such cases when they come to the OR, then you always have to decide on a FOB or a videolaryngoscope. But in such scenarios where mouth opening is restricted, you doesn't have a space to work in intraorally, then FOB is always the best option for such cases. Awake intubations, how do I do it? So prior, as it is an anticipated difficult airway, you have time. You need to talk to the patient, you need to counsel the patient that what procedures we are going to do with him and all, so that it cuts down his anxiety and all levels. Then we'll decongest, we'll use some decongestant drops in the nasal so that when we are trying to intubate through the nasal cavity, it shouldn't bleed or something kind. Pre-oxygenation, as sir was mentioning prior also, pre-oxygenation plays a huge role in such patients. How do we pre-oxygenate such cases, and how do you oxygenate in the apneic period? I'll discuss in future. And use of antisyllagogues, anxiolytics, a small dose of analgesics, and apnea oxygenation whenever the patient is into apnea, going into apnea, or just sedated or so. And mild sedation in operating rooms, you have the luxury again with inhalational agents, intravenous agents like propofol or dexmedetomidine. You need to have a good suction all the time, whether it is operating room or ICU. And we usually give upper airway blocks whenever we are planning for an awake intubation. That really gives a good scenario for intubation. So this IV anesthetic agents, inhalational agents, and upper airway blocks will optimize your airway whenever you are doing for an awake intubation. So not these are the upper airway blocks. We usually block the superior laryngeal nerve and the tracheal blocks. I'll not go into deep in those things because ICUs we usually doesn't do such things. And this is what sir was also mentioning. Actually, this is the apneic ventilation. How drastically you see the oxygenation falls after the patient goes into apnea. And this is more with the obese patients actually. So you need to be prepared for that. As faster the patient goes into apnea, the less time you have to deliver your procedure actually. So to avoid such things, what we do, we put a nasal cannula, we try to connect it to a breathing circuit and oxygenate the patient whenever the patient is in apnea. Or nowadays we use HFNC machines or CPAP machines to deliver oxygen. And in obese patients, whenever you are already in ramped up position, try to put 40 degrees or so and try to pre-oxygenate well the patient so that the FRC will increase and they will be getting pre-oxygenated well and all. And once the patient gets induced or something kind of, then try to reduce your angulation to 20 degrees or so and then try to go ahead with the intubation process in obese patients. So Ambuscope, again, great asset whenever you are going for an anticipated difficult airway. But usually they say visualization is not always. So you visualize the glottis, you have gone through the vocal cords, but still you find some problem pushing the ET tube inside. So whenever you have a left-facing Murphy size or bevels, they get stuck up or hold up at the arytenoids. So this usually happens whenever you are trying to thread a ET tube over a fibroscope. So in such situations, try to rotate the ET tube anti-clockwise 90 degrees or so, and then go ahead with the intubation process. That would be a better scenario. And we have been listening different kinds of videolaryngoscopes. The most common would be the McGrath and the glidoscopes. The difference in between both of them is one has a monitor attached to the scope itself, the other we need to carry a monitor with the scope again. McGrath has been more popular because of attached monitor to the scope itself so that we can mobilize it to different areas in the hospital and go ahead with the difficult airways. How do I perform with the videolaryngoscopes? Try keeping the head in more neutral position, don't manipulate the head much, and try to negotiate with the videolaryngoscope slowly. Do not insert the scope blade too deep because it's something kind of rear glass of your car. The object will be more nearer than what it is seen on the screen. So try to stop yourself whenever you are trying to see a glottis or a glottic opening, and then negotiate your tube. Do not insert the tube, ET tube too posteriorly. If you insert the tube too posteriorly into the oropharynx, then it gets hinged up. I'll just show you the pictures. Do not forget to lift the blade and the jaw. Whenever you are using a videolaryngoscope, don't think that everything will be seen. Okay, try to use it as a conventional laryngoscope. Try to lift the jaw a little bit and try to visualize into it. And try to insert the tube normally as a conventional method. Don't try to see in the screen and then move the ET tube because problems may occur. So whenever you are trying to insert the ET tube, conventionally you put the ET tube inside and then you start seeing the tube on the screen and then negotiate in front. I'll just show you what happens actually. And don't hesitate to ask for external laryngeal maneuvers like cricoid pressure or burp maneuver, so that it makes your life easy and visualization easy. This is what happens whenever you are putting a ET tube more posteriorly. So the catch here is, whenever you are trying to see a ET tube coming from the bottom of your screen, then you are in a wrong direction. So it will get hinged up somewhere here. So, and you can think that your ET tube is more posterior in the oropharynx. Your tube should be entering from almost a right side corner or right upper quadrant. So that way you need to focus on whenever you are doing a videolaryngoscopy and all. And this is what happens whenever you are trying to negotiate seeing on the screen. The tube has gone through the soft palate and into the glottis. So always try to visualize the position of the ET tube, how you are entering inside and all, then you negotiate the tube. So when you have failed intubating and all, you land up in cannot intubate, cannot ventilate scenarios. And there are many algorithms, difficult airway society algorithms and all. Everybody says the same thing. Do not attempt more than 3 attempts actually. If 3 attempts you have failed intubating, declare it to be a do not intubate case. Okay, we'll see in further slides how we go ahead. After first failed intubation, do not repeat the same procedure. Okay, either change the blade or change the scope or change your maneuver, how you are inserting the blade and all, or take a smaller ET tube. You don't know what is going wrong. When you are not understanding, try to change the procedure. Ensure adequate paralysis, and if somebody is giving a cricoid pressure, try to remove the cricoid pressure and see sometimes, so that your visualization will be optimum at that time. Do not try more than 3 attempts before declaring a failed intubation. 3 plus 1 attempt, if an experienced person is there, you can opt for it, but call for help always. And whenever you have declared it to be a cannot intubate and can ventilate procedure, try for a supraglottic device. Always prefer second generation supraglottic airway devices, because they have, as in the morning class you have seen, they have a gastric drainage tube so that you can aspirate off the gastric contents easily. Once the supraglottic airway device is secured and ventilation is good, then stop there and think what to be done further. Discuss with the team what to be done. In operating rooms, okay, it's feasible, sometimes we wake the patient up back again, but ICUs, it's not a possible thing. We had a similar scenario recently where a CKD patient presented with IC bleed, and he was altered mentation, and gradually he went into a comatose state, and ER physician has tried almost thrice and called for us. Then when we went in, there was a huge trauma and edema part. Hardly we gave 1 intubation. Then we went with a supraglottic airway device, secured it, getting ventilated, pushed it into ICU, then decide on what to be done, because we need to have a fixed airway there. So we had a facility of going for the tracheostomy. We went for the percutaneous tracheostomy directly. But you can think of other options also, like you can intubate through an LMA. Okay, so you have secured an LMA, you are able to ventilate, ventilation is good enough, then think whether you can go ahead with an intubation through an LMA. But it's always best you go with a fiber optic intubation. You thread the ET tube onto the fiber optic, go through the LMA and pass the ET tube, or thread a tube exchanger onto the fiber optic, go through the LMA and secure your tube exchanger and do a railroad technique to push the ET tube inside. So this can be done. If you have failed, then it's a cannot intubate, cannot ventilate situation. After first failed supraglottic airway device, do not repeat this procedure same again. Either change the procedure or change the supraglottic airway device. Always try to use the most familiar supraglottic airway device what we are equipped with. Okay, don't do trials or don't do experiments over there. So ensure adequate paralysis again. If somebody is giving a pressure, remove the pressure. Do not attempt more than three attempts. If third time also you fail, you declare it to be a cannot intubate, cannot ventilate scenario, and call for help and try for front of neck access. Whenever you are planning, there is some time there again. Whenever you are trying to plan for a front of neck access, you can give still a try with a supraglottic airway device, but pull in the people for front of neck access. Sir has already mentioned about this maneuver. So laryngeal maneuver where you try to locate the cricothyroid membrane, and with the scalpel method you will insert a bougie and over that a ET tube, or so. This will be discussed in the workstations. I'll try to focus on how you do with ultrasound. As I'll be taking the afternoon session with the airway ultrasound and all, we'll be focusing on two techniques of locating a cricothyroid membrane. The two techniques, first is string of pearl technique, the second is Taka technique. How do you do that? Okay, so whenever your patient, as we are dealing with anticipated difficult airway, so whenever you are anticipated, you can mark your cricothyroid membrane prior itself so that you can plan things. So I'll put my linear probe in the suprasternal notch. I'll be visualizing something kind of like this. The trachea in center with the air column below. Then I'll try to slide my probe onto the right side and get the trachea into the corner edge. Then I'll rotate my probe 90 degrees and start seeing string of beads or string of pearls kind of thing. Once I see this scenario, I'll try to push my probe more cephalad so that I see this first bump coming or the biggest